Yogesh, can you hear me?
Yeah. Tell me. So can you see my screen, Saurabh? Are you seeing my screen?
Yeah, I can see your screen. Yes.
Okay.
दिख रहा था. रुक मैं मेरा just कर लेता हूँ इसमें से.
कर ले उधर से, मैं तेरे को म्यूट कर लूं क्या 2 मिनट के लिए, so that ये मैंने म्यूट कर लिया तेरे को, ठीक है? Yeah. Qureshi sir, good evening.
Hello, good evening.
Yeah sir, can you see my presentation, sir?
Yeah, I can see. Are you able to hear me clearly?
Yes sir, we are listening to you clearly, sir.
And do you see me also?
No sir, I can't see you.
But that is okay. Not necessary. हाँ?
आप लैपटॉप पे हो या मोबाइल पे हो?
नहीं, मैं मोबाइल पे हूँ.
हाँ, तो मोबाइल पे मुश्किल रहेगा सर दिखना. Okay, so we have around 25 people right now. We'll wait for 2-3 minutes, sir. Up to 30-35. As soon as we cross, we'll start.
Hello.
हाँ sir.
You are able to hear clearly?
Yes sir, एकदम clear आ रहा है सर आवाज आपका. बिल्कुल कोई इशू नहीं.
Okay. You just tell me whenever we are good to go. I'll start.
Yes sir. Sir, दो slides है. First slide and then second one.
नहीं, ये तो मेरी एक ही है.
नहीं,
आपने और एक बनाया क्या?
नहीं आपने ही भेजी है सर. दो.
नहीं, मेरे को कुछ नहीं करना. यही स्लाइड दिखाना है सिर्फ.
Okay.
नहीं, वो छोड़ दो. वो उसको डिलीट कर दो या मत दिखाना.
नहीं ठीक है, वही एक दिखाता हूँ, कोई इशू.
वो गलती से आ गई, वो कॉपी पेस्ट किया हुआ है.
No issue. ठीक.
It doesn't matter actually.
So 29 are there online.
एक देखते 2 मिनट रुकते थोड़ा.
हाँ सर ठीक है ना, ये 8 ही बजे है. Wait for 3 minutes.
Yeah.
Rahate sir, good evening. It's not online. या कुरैशी सर?
या
31 ऑनलाइन है और
बोलिए
थोड़ा या 2-3 मिनट रुक जाते हैं सर, 2 मिनट और एंड देन विल स्टार्ट.
ओके, ठीक है.
I'll just give an introduction. So good evening everyone. Today we have a special lecture on management of upper GI bleed. As a surgeon, we always get these type of patients who come to us with hematemesis or sometimes melena as a presentation of upper GI bleed. So we thought of getting a medical gastroenterologist to speak about it. how to manage these things medically, how to do intervention like endotherapy, specifically banding, glue injection for if it's a variceal bleed, or if it's an ulcer bleed, how to take care of that. So that lecture will be delivered by Dr. Saurabh Mukewar, is a consultant at Vilas Multispeciality Hospital. Before that, we have a special message from our ASN and VSA members, which will be delivered by Dr. Qureshi sir. So with his permission, I guess we should start it because we are around 32 people online and it's already past 8. So I hand over the proceedings to Dr. Qureshi sir. Sir, please go ahead.
Yogesh, can I go ahead?
Yes, sir.
So, good evening, ladies and gentlemen. This is a very special thing which I have been asked to do. And you must have read in WhatsApp and in news regarding the distressing news and events around the death of Dr. Simon Hercules in Chennai. And it was so disturbing that I thought that if the society at large cannot give dignity to a fellow doctor, why can't we join together? If we can clap for people, we can blow the conches. Why can't we stand in silence for 2 minutes for a friend and do a little bit so that it will bring some dignity in this hour of death? And I was really surprised to see when I went on the internet that this was not the one isolated case. This has happened in the case of one Dr. John Silo in Meghalaya, and indeed in Dr. Lakshmi Narayan Reddy's case in AP, and it is widespread. So I think there are a lot of things which have to be done, and the national president has already written to the Honorable Prime Minister regarding this, and things will be done. But we are doing our small bit at ASN and VSA to give our respectful homage to all the not only the doctors but all nurses and all health workers who have lost their valuable lives in the line of duty. So to all the members who are logged in at this moment in this webinar, I would request them wherever they are to stand for 2 minutes in silence and pay our respectful homage. Please stand. Thank you very much. Yogesh, you can continue. Thank you.
Thank you, Qureshi sir. So now I'll take Saurabh online. Yeah, Saurabh, you are online. You can start your screen sharing. By that time, I'd request Rahate sir to just give a brief introduction about the topic, why it is important to all of us and all. By the time Saurabh gets his slides online. Saurabh, show your screen.
Yes. Okay, 1 second. I'm just coming on. 1 second.
Rahate sir.
Yeah, good evening all. Saurabh, I am audible?
Yes,
Yes,
sir,
yes, I can hear you. Thank you.
Am I? Yes. Yeah, good evening all. This topic is very important because a number of times we come across this type of emergencies. As we as a surgical fraternity, even at the level of the national ASI, they are going up with the training programs of the surgeon in upper GI and lower GI. So the surgeons, they should take up this issue of doing upper GI and lower GI. They should have a proper training. And what exactly, how to manage this? This is one of the simplest thing to be managed, but at times it becomes very difficult to manage. So we need in such situations experts like Saurabh's guidance how to manage such cases. But the baseline, you should know as a surgeon how to approach this upper GI bleed, how to manage. And Saurabh needs no introduction at present because he is going leaps and bounds. Whenever you are going to hear Dr. Saurabh, you are going to be updated. Whatever knowledge in world we are having. So let us hear Saurabh. Please, Saurabh, go ahead.
Hi, good evening, everyone. Thank you for inviting me. I am truly honored. Thank you, Dr. Hate and Yogesh, for inviting me. This is my first webinar, so please excuse me if there are any errors on the technical side from my end. I'll be talking about upper GI bleeding, and I recognize this is a very frequently encountered issue. At least at Midas, we are used to seeing this very often, and we've had a good experience managing these patients. So I'd like to share and showcase some of the cases that are done and how we manage these patients. So let's go through the basics. What is upper GI bleeding? And upper GI bleeding basically would be any bleeding proximal to the ligament of Treitz. So any source of bleeding in the esophagus, the stomach, the first, second, third part of duodenum would be considered as upper GI bleeding. Now, how does it present? 70 to 80% patients would present with melena. And hematochezia as a presentation of upper GI bleeding is quite rare. And if it occurs, then these patients generally are bleeding profusely, and they're usually in shock. And as you see, it's because the time for the blood to turn from red to black is how much time it has in contact with acid. So if the blood is in contact with acid for a short period of time, then it doesn't get enough time to turn from red to convert to hematine, which is black, and therefore hematochezia would generally imply large profuse bleeding in these patients. 50 to 60% can present with hematomesis, and another similar number with coffee ground emesis. Now, what are the factors that predict upper GI bleeding versus lower GI bleeding? When we know patients have GI bleed, but it's unclear, and this is the data of thousands of patients where patient-reported history of melena, the likelihood ratio was 6. Melanic stool on examination, which is different because sometimes patients feel that they have dark stool, but when you examine, it's just dark green. And when you truly have melena, it's the likelihood of having upper GI bleed goes up to almost 25. Nasogastric lavage with blood or coffee ground is almost 9.6 times. BU and creatinine ratio is something we also look at, which if it's above 30 would imply upper GI bleeding. Blood clots in stool reduces the likelihood that it's upper GI bleeding. So we'll just show you some basic causes of upper GI bleeding. So it could either be some sort of an inflammatory, erosive, or ulcerative process in esophagus, gastric, or duodenum, where bottom left it's severe esophagitis, bottom right you see an ulcer. On top right is the Cameron's erosions, which can oftentimes be missed in patients with hiatal hernia. They have these linear erosions, which can lead to sort of slow oozing upper GI bleeding. You could also have it secondary to vascular lesions like Dieulafoy's lesion up on the top right, which is basically a submucosal vessel which just comes out above the mucosa and starts bleeding profusely. And the bottom right is your standard esophageal varices, which I'm sure all of you have probably seen at some point. And bottom left is what we call as arteriovenous malformations or angiodysplasias. These are vascular malformations in the mucosa, And this typically leads to sort of slow oozing GI bleeding. Oftentimes you see in small bowel, or you can have it from polyps or malignancy, or it can be from a more traumatic injury such as Mallory-Weiss tear, which happens when patients vomit and lead to a tear in esophagus and there's bleeding. Or it can be from any iatrogenic cause where, say, in the middle you see post-ERCP sphincterotomy, which led to bleeding. In the right is a picture of post-polypectomy, oozing and bleeding from the site. So data from the West has shown largely peptic ulcer and gastritis is the most common source of bleeding. But in India, there are various studies from different parts of the country where in some parts, duodenal ulcer seems to be the most common reason. In other parts, esophageal varices is the more common reason for GI bleeding. But certainly from our experience in ISG, which is Indian Society of Gastroenterology Task Force, the portal hypertension is much more common in the Indian context compared to West. Initially, when you approach these patients, you need to understand what's the severity, what's the source of bleeding, comorbidities, as this will assist in management. It's almost a no-brainer when patients have cold, clammy extremities, angina, lightheadedness would imply severe upper GI bleeding. Orthostatic hypotension, which would mean when you're lying down, there's no blood pressure is stable, but as soon as you stand up, the blood pressure drops or the pulse increases, which would imply a significant bleed, but these patients are not hypotensive at baseline when they're lying down. Factors which predict severe upper GI bleeding generally include history of malignancy or cirrhosis, syncope, as you would expect, tachycardia, hemoglobin level less than 8, as it's intuitive. Now, with the history, you need to understand what could be the source of bleeding. So if the patient has a prior history of GI bleeding, most likely the odds are that's probably the source. History of liver disease, history of alcohol consumption, history of NSAIDs, which oftentimes people don't mention in their medication history, and it has to be extracted out of patients. Patients, if they are anticoagulants, antiplatelet agents, which would imply that if you're on something like clopidogrel, even trivial sources of small erosions can lead to severe bleeding. Patients on iron supplements, they can have dark stools, which they attribute and say that they have melena, but they actually have just dark stools. Sometimes your classic history can help you understand what the source of bleeding is. So emesis, non-bloody followed by blood, can sometimes imply a Mallory-Weiss tear in routine patients. Patients have cachexia, weight loss, likely from malignancy. Sometimes when you have a clear cirrhotic patient with abdominal distension and jaundice, can be from variceal bleeding. It's important to understand the comorbidities as you're managing these patients. It's if the patient has history of coronary artery disease or COPD, then your goals of transfusion are different. If your patients have, sorry, quick poll on the screen. If you have patients with chronic kidney disease or heart failure, then you may want to be cautious in terms of how much you transfuse these patients. If patients have clotting difficulty, or then you may want to check for coagulation factors and then transfuse accordingly. And then if you have patients with encephalopathy, then you may have to intubate these patients and protect their airways. So I understand one popular demand. I've decided to focus on more cases and videos illustrating the GI bleeding. So let's start with the case here. 23-year-old male presented with epigastric pain since 1 month. He had emesis since morning with spoonful of bright blood in the last 2 times he had emesis. No significant past medical history, no history of NSAIDs, no alcohol, smoking, slightly tachycardic on examination, mildly febrile, and lab showed mild leukocytosis. Initially, hemoglobin was 14.7, and 24 hours later, checked was 12.4. And this is something to note, because initially when patients have GI bleeding, you check hemoglobin, it could probably be normal, but once you start giving them fluids and then there's recalibration, and then actually the hemoglobin goes down. And so this particular patient actually had Mallory-Weiss tear, And I'll show you this endoscopy. This was just performed within the last 2 weeks. On the left here, this is the gastroesophageal junction. And I have a clip here. It was hard to see the Mallory-Weiss tear, and it takes a little while and some experience doing endoscopy. And I will pause it when you'll be able to see the tear, which is very small right there. Actually, this, sorry, yeah. So right there. So right here, I paused it right here, just below the G junction. You see this area. This is the Mallory-Weiss tear, and I decided to go ahead and clip it. As you see, there's slight oozing of blood from that area, and ultimately you get a clip across. And it's also important for you to understand what's the technique of placing a clip, because it's so you have to basically push the clip out, and then as my senior used to teach me, you have to plant the flags. You have to push it at the base of the lesion and then close it, so then you can effectively clip it. And as I see in this video, I just reverse it here. So we place it at the base, close it, and deploy it. Okay, we move forward. Another patient, similar case. This patient had a little more obvious Mallory-Weiss tear and the submucosal tissue protruding out. In this case, we decided to proceed with band ligation, which can be an option, which we use for variceal ligation. I suction this mucosal tear inside the endoscope, and then we place bands. So this patient actually recovered well, discharged the following day. 4 weeks later, just recently now, he had no additional bleeding events. All right, so I have put in some questions. I recognize we can't really answer them, but just to make you think, what is the optimal timing to perform upper GI endoscopy in patients with severe upper GI bleeding? Within 3 hours, 6 hours, 12 hours, or 12 hours? So I'll give you a second to think. It's actually within 24 hours. So just hot off the press, this is a New England Journal article published this year in April 2020. Patients with severe upper GI bleeding underwent endoscopy within 6 hours or within 6 to 24 hours. There was no difference in rebleeding rates. There's no difference in mortality between the two groups. But from personal experience, there are some patients I suppose may benefit from early endoscopy, but on this large randomized controlled trial, there was no benefit. It's probably, we'll still have to find which are these subset of patients which actually will benefit from certainly urgent endoscopy. All right, let's look at another case. 72-year-old male with past medical history of diabetes, hypertension, suspected ischemic heart disease, presented with melena ×3 since 24 hours, sweating, lightheadedness since morning, no history of alcohol or smoking. Medications include aspirin, 81 milligrams, telmisartan for blood pressure, rosuvastatin, metformin. He was tachycardic with a pulse of 134. Blood pressure was low, 80 over 50, conscious, NO ×3. Lab showed hemoglobin down to 5.7, white count elevated 20,000. He had acute kidney injury with creatinine of 2. And as you see, BU and creatinine ratio is high, above 30, and normal LFTs. INR was normal at 1.2. So overall, this patient had suspected upper GI bleeding. We performed endoscopy rather soon. And as you see in the duodenum, you see this little ulcer, and there is a visible vessel right there at the far end. And what we are using in this particular case is a bipolar cautery device. This is available in different sizes, and the key is that with this device you have to apply it with some degree of pressure on the targeted vessel, and you have to keep cauterizing not for like 1 or 2 seconds, but actually for about 5 to 10 seconds, and keep maintaining the pressure that will actually cauterize the vessel. People make mistakes and they just cauterize it for a second, and then the vessel can actually burst and bleed, and then it gets really, really hard to control. So that's something important while you're using this device. So patients improved with no additional bleeding episodes. Overall received 3 units of blood with appropriate response. He was discharged 3 days later. He was in ICU briefly on pressors as well. So let's understand, when we talk the language of upper GI bleeding, what are the possible scenarios, and this is what we term as a Forrest classification for peptic ulcer bleeding. On the top left is the worst type of lesion that you can encounter is type 1A, in which there's a spurting arterial jet from the ulcer. Type 1B is slightly less severe with constant oozing from the ulcer site. Type 2A on the top right is an ulcer with a visible vessel in the middle of the ulcer, as you see here. And type 2B is an adherent clot. Type 2C at the bottom is just a black spot at the site of ulcer base. And type 3 is just a clean based ulcer. What we understand is, based on the type of Forrest classification of ulcer, it determines the risk of rebleeding. On the top left is the spurters, which have active bleeding. There's a high risk of rebleeding. And as you go down the Forrest classification, the risk of rebleeding gradually goes down. And okay, so I'm going to ask another question here. I think this is very important because this, and I highlight the point. Should aspirin be stopped in patients with upper GI bleed? I'll give you options. Aspirin should be stopped since patient is at risk for further GI bleeding. Aspirin should be stopped because there's no increased risk of cardiovascular events in the short term if you stop aspirin. Aspirin should not actually be stopped because the patient has increased risk of cardiovascular events in the short term. Aspirin should not be stopped because there's risk of GI bleeding is not increased if you continue aspirin.
Saurabh, 1 minute. We can wait for 5 seconds. I'll ask all the attendees to put your answer A, B, C, or D in the questions panel so that I can see what most of the people are answering. So you have these 4 options. You are seeing it on your screen. In the question panel, where you can ask the question, you can put option A, B, C, D so that we can see how many people answer what. Just we'll wait for 5 to 10 seconds so that people respond, and then we'll go ahead. Okay. Yeah. So in your question panel, I can see the answers pouring it. So yeah, we are seeing the answers.
Okay,
so
very
it's a
good.
mixed response from most of the people. So it's a D by some people, A, D, C, A, B. This is what I'm getting. Yeah, maximum people are answering B. Yeah, maximum answers which I have got among 15 answers I have got, 15, 16. Most of the people have answered B. So Saurabh, you can give the answer what exactly it is. Yeah.
Okay, so the answer is actually C. Aspirin should not be stopped in this patient, which I showed you earlier, because he's at increased risk of cardiovascular events in the short term. I think this is essential for everybody to understand when they're managing any patient with upper GI bleeding, because this was a question answered in this particular study in 2010, where patients with history of cardiovascular events and actively came with GI bleeding, what was learned was if you continue aspirin, the risk of rebleeding within a month was 10.3% with aspirin versus 5.4% with placebo. However, when you look at the mortality, if you continued aspirin, the risk of mortality was down to 1.3%. But in patients, when you stopped aspirin, it was 12.9%. So therefore, in these patients, you have to continue aspirin, but treat the ulcer, treat with PPIs, as I'll go through in the upcoming slides, and manage these patients. Okay, let's understand some basics of platelet aggregation and acid environment. These are old studies which have really defined how we manage these patients now. If you look at the chart on the left, what you see is when you're in an acidic environment, platelet aggregation is very low, as shown in this pH of 5.9, where there's limited platelet aggregation. But as soon as the alkaline environment, as soon as the environment can be made alkaline, the platelet aggregation starts going up. What it means is, in patients with GI bleeding, you don't want an acidic environment. You want to keep the environment alkaline, and that's why you use acid suppressant medicines, which can basically ensure that platelet aggregation takes place and the patient's bleeding is controlled. Now, on the top right, on the right is the graph, which again showing when alkaline environment is created by on point B, again platelet aggregation improves. So the options are PPIs versus H2 blockers. I think this is not a question of debate anymore. We recognize that PPIs have consistently shown over time in this meta-analysis to have reduced risk of surgery and rebleed if compared to H2 blockers when you're managing GI bleeding. Now, high-dose PPIs prior to endoscopy reduces the need for any sort of therapy with endoscopy. This is another landmark study from New England Journal of Medicine, where people were given PPIs versus no PPIs before endoscopy. What they found was the length of stay in hospital is less. The chance of finding high-risk stigmata, as I showed you in the Forest classification, actively bleeding peptic ulcer, ulcers with non-bleeding visible vessel, was less when you receive PPIs before endoscopic therapy versus not. But there's no difference in mortality, surgery, or rebleeding between the two groups. High-dose PPI after endoscopic treatment of actively bleeding ulcers or visible vessels is also essential because it reduces your risk of rebleeding, another landmark study. No mortality or surgery benefit in these patients. The type of PPIs that are available, we generally would use any of the any of these four can be used, where generally you give a bolus of 80 milligrams of either pantoprazole, esomeprazole, or omeprazole, followed by 8 milligrams an hour infusion. Patients, if they're actively bleeding, hemodynamically unstable, you definitely have to give infusion. If patients are stable with some melena, a PPI BID can be considered, or PPI infusion is fine as well. After endoscopy, if the patients have high-risk stigmata, which is what I showed you earlier, actively visible vessel which is bleeding or just a non-bleeding visible vessel, you want to continue PPIs for a total of 72 hours with IV, and then you can switch to high-dose oral PPIs for 2 weeks and then switch to once a day after. If you don't have high-risk stigmata, which means you have just a adherent clot or just clean-based ulcer, you can immediately switch to oral PPI, standard dose, doesn't have to be high dose. The other medicines which have started using more and more is prokinetics before upper GI endoscopy. Really, for people who do this routinely, when there's active blood, it's really a tedious job and you have to clean and remove all the clots. So using a prokinetic like an hour or two before the upper GI endoscopy can really be helpful, as it clears the stomach and helps you visualize the lesion. As shown in this meta-analysis, where gastric mucosa visualization was better with the use of erythromycin. Relook endoscopy was less because you've cleaned the stomach. There's no difference in the terms of how much transfusion was needed, duration of procedure, or surgery based on this meta-analysis. Okay, I have another case here. 70-year-old female with history of coronary artery disease in Cabbage in 2003 presented with melena since ×2 since morning and shortness of breath. Patient has no history of alcohol, tobacco. Patient was taking clopidogrel and aspirin 81. Temperature, vitals were largely stable, and EF of 54%. Labs showed hemoglobin down to 7.8, and otherwise largely unremarkable labs. So this patient, again, was a recent case that I managed. This in the gastric antrum, you see this ulcer. Now this is an ulcer with a non-bleeding visible vessel, as we would term it, and just getting you a closer view. So we decided to inject some epinephrine in submucosal tissue around the ulcer. Now it's important to understand that when you're using the epinephrine, you don't actually have to inject inside the ulcer. You can inject around it to create a submucosal cushion as it infiltrates the tissues. And generally the concentration used is 1:10,000. So you have to really dilute the epinephrine that you use, that's available in your vials. And then you inject on both the sides around the ulcer so that there's nice infiltration of the epinephrine. In this particular case, I decided to use a clip, and I'll show you in a moment here. Here the clip is placed right at the ulcer, and we close it to oppose the edges and achieve hemostasis in this case. So this patient did well. Again, no additional bleeding episode, received a unit of blood, and was discharged in 2 days. Okay. So in terms of endoscopic therapy, you have a variety of options. I showed you bipolar probe earlier, and now I showed you clip. But what we understand is there's really no difference between using bipolar cautery or clips. You also inject epinephrine, and what we have seen is epinephrine injection plus any form of endoscopic therapy is superior to using epinephrine alone. So therefore, if you're managing these patients, injecting just epinephrine will not do the trick. You will have to either cauterize or clip these vascular lesions. So what are the predictors of rebleeding after an ulcer bleed? Hemodynamic instability on presentation, active bleeding as shown in the top left, active ulcer, large ulcer more than 2 centimeters in size, location, posterior duodenal ulcer. These are very challenging to manage with endoscopy, and along the lesser curvature, high up on the lesser curvature can be difficult to manage. And these patients actually end up having a high risk of rebleeding later. Okay, another case here, 43-year-old female with extrahepatic portal venous obstruction. Actually, let me move back a little bit. I think we may have. Okay, never mind. Just proceed forward. So 43-year-old female with extrahepatic portal venous obstruction and portal hypertension, diabetes, presented with hematemesis since 2 days, melena since 3 days, times 3 since 1 day. History of banding 10 days ago in an outside hospital before she came to us. Her vitals were stable. Lab showed hemoglobin slightly low at 10.3, platelets were marginal, 155,000, INR was 1.2. This patient, actually had esophageal varices, and I'll just show you. Now she had banding performed outside about 10 days ago, and here we advance the endoscope. I'm just skipping forward the initial EGD and going ahead with the banding video here. So as you see here, patient had large columns of esophageal varices and ulcers from recent banding. Now I'll just pause for a second. So all this here, these are large variceal columns, and this is here, right here is the ulcer. And those, as you see, there are some bands residual from before. So we decided to proceed with placing additional bands now. Okay, sorry. Let me see here. You see this huge, large column of varices. They're quite scary looking at them. I'll show you in a few seconds. On the right side of the screen, you will see what we term as a nipple sign, and it's important to recognize that. Just move forward a little bit. Right there. So I'll pause for a second. Right here in the middle of this varix, you see this red. This is a hemocystic spot or a nipple sign. And what this implies, this is a fibrin clot at the site of the rupture of the esophageal variceal bleed. And then actually this patient, quite impressive findings. I'll show you again. And another one of these just below, right there. This is another area with a nipple sign. So we decided to place a band across right there. I tried to grab both of them together in this, and we placed the band successfully. There was some oozing, but then this was controlled. Okay, we ended up placing 2 bands there. Anyway, so I'll move forward. So just some basic tips for people who actually perform esophageal varices and variceal banding. So basically you start at G junction and then move upwards. So you'd like to band every 2 centimeters or so in a spiral fashion as shown here. So you start with one column and then come up a few centimeters, do another column, and then another few centimeters, another column, and then just keep moving forward. A nipple sign, as I showed you earlier, is a stigmata of recent bleed. First, ideally, you should put a band here if you recognize it first. Once suction, don't let go of the varix, because then the varix can rupture and then there's a lot of blood and then you can't control it. Remember the pink sign. What it means is you have to suction properly. You can't do half-hearted suction, because then you will not get the varix in. You will not be able to deploy the band properly. So suction so that the entire varix is right in your face and the entire screen turns pink, and then put your band across. If you have small previously treated varices, sometimes they have scarring, don't get scared. Just move your with your right hand on the scope, just move it back and forth, rotate it, and get the varix inside. Sometimes you may have to electively intubate these patients if they are profusely bleeding. This patient did well, no additional bleeds, was discharged in 4 days. Well, I have another question. Well, okay. The AASLD guidelines for prevention of recurrent variceal hemorrhage. Now, what do you do after you do these bands? You replace these bands. They say every 1 to 4 weeks until eradication of varices, you continue putting bands. Sometimes it requires 2 or 3 sessions, sometimes more. The goal is ultimately you have to have enough scarring throughout the esophagus so that all the vessels are eradicated, and then after that you can switch your intervals to every 3 to 6 months, and if it's okay, then space it out more. What's the hemoglobin threshold for transfusion of PRBCs in patients with acute upper GI bleeding? Now again, these are all regular patients without any ischemic heart disease. So you guys, everybody can start putting.
Please answer. We'll wait for 10 seconds. You can please answer quickly. So yeah, we are getting responses. We'll see. So it's for non-cardiac patients, right, Saurabh?
It's non-cardiac patients. Yeah. I should have mentioned that.
Yeah, okay. So there is 7. So we have responses. I'll read quickly. Okay, whichever are 7. A, B, A 6, B 7, 7. Some have mentioned A 8 as the cutoff. D is totally wrong. I know 9 is not the answer. So maximum answers which we have got is 7. B. B is the response which most of the people have given.
Correct.
7
so that could be right. It's actually 7. And this is again another landmark New England Journal study here. Restrictive transfusion strategy is associated with greater survival than liberal transfusion strategy in these patients with severe upper GI bleeding. And if you see, restrictive strategy was goal hemoglobin of 7, and liberal strategy, the goal hemoglobin is 9. So as you see, the curves in the Kaplan-Meier curve diverge, with patients with restrictive strategy having better outcomes than those getting liberally transfused. Now, when they looked at the data in detail, as you see in this table at the bottom, mortality was low with restrictive strategy. Further bleeding events were less with restrictive strategy. In patients with cirrhosis, you can see a stark difference, 12% versus 22%. And this difference was marked in child's A or B patients, and bleeding from esophageal varices was also lower. Now, what happens if you liberally transfuse these patients with portal hypertension is that their vasculature gets engorged with blood, and therefore there's increased pressure in the varices, and that leads to further bleeding and higher mortality. And that's the rationale behind having a restrictive strategy versus a liberal strategy for transfusion in these patients. Again, not applicable to patients with ischemic heart disease, where your goal is about 8 to 9, but 7 would be fine in regular patients. Now, again, the caveat is when patients are actively bleeding and profusely bleeding actively, yes, hemoglobin is 6, doesn't mean you transfuse 1, you may actually have to give 2 or 3. But again, the idea is that you don't have to over transfuse these patients. Just maintain hemoglobin about 7 or so should be fine. transfusion recommendations. Otherwise, for platelets, 50,000 is the cutoff. For INR, FFPs, INR above 2, we would generally transfuse. For taking them for endoscopy, if the platelets above 20,000, we are generally comfortable doing endoscopy in actively bleeding patients. INR below 2.5 should be fine. Above 2.5 or platelets below 20, we like to have transfusions going and get hemostasis. Proceed with endoscopy once we actually have decent levels. So if there are any people who practice platelet transfusion in patients with taking antiplatelet agents, I would recommend stopping, because there's no benefit of transfusing platelets if patients have platelet count above 100,000 and are taking clopidogrel or aspirin, because in this particular study, as you see, the mortality was greater in patients who were given platelet transfusion, and there was a trend towards higher cardiovascular events and myocardial infarction in these patients. Okay, let's move forward. Another case here, 50-year-old male with history of chronic pancreatitis, alcohol consumption, cirrhosis with portal hypertension, child's B, MELD of 9, presented with melena 7 to 8 times since 1 day. No history of smoking or NSAIDs. Vitals were largely stable. Hemoglobin initially was 9.4, but in 24 hours down to 7.5. Otherwise, creatinine was 1, mildly increased, but nothing remarkable otherwise. So this patient turned out to have a large gastric varices, and on endoscopy here, you see this large bleb of vessels in the fundus, which is the gastric varices. So we decided to proceed with glue injection in this patient, and we interrogate the varices closely. As you can see, there are some red spots here, lightly bled from these spots here. So we start with just getting the right angle in place, and then basically we jab the needle inside the varix, suction, and as you see, there's some blood coming out, confirming that the needle is actually inside the varix. And then we proceed with injecting glue. Now, once we inject glue, we don't immediately pull it out. We usually wait for about 10 to 20 seconds to ensure that the glue solidifies inside, because if you remove and pull it back too quickly, it'll start bleeding in again and then obscure views. And then eventually now you pull it out, get the needle in, and then as you can see, the other sites which can be targeted. We get another site over here on the left. You see there's some glue coming out right here. And then we proceeded with a third site right up there, which is still, as you see, it's plump. This area is not solidified right here. And again, glue is injected. Okay, there. So ultimately, hemostasis is achieved. What I'm not showing here is, again, after you have injected glue, you can just blunt probe that varices, and you can see it's hard. And if it's hard, then you're confident that there's enough glue and it has solidified inside. You're not always that lucky. Sometimes you encounter active bleeders, as seen here. See, this is quite impressive. There's active bleeding from this gastric varices here. So this patient again decided to proceed with glue. So you have to do it rather quickly, because your view can get obscured soon, and then it's hard to control bleeding then. Again, glue is injected, and just pull it out and stops bleeding right there. What's new is what we have started doing at Midas as well, is EUS guided coil injection. And this is another gastric varices. Again, this I have taken it from one of the journals, this video. And as you see, in endosonography, we can actually visualize these veins. And I'm going to pause for a second here. This dark structure here near the probe, is the vein. The advantage is that you don't have to worry about your views getting blocked, and you can just under endosonography visualize these blood vessels, and you advance a needle inside, and then you deploy a coil. As some of you may know that interventional radiologists can use coils for stopping bleeding, and that's what we can actually do with endosonography. And in this patient shown here, hemostasis successfully achieved with placing of coils. We now actually use a combination of glue and coils would be our frontline treatment now, as it's supposed to be superior to just glue injection in these patients. So, okay, I have another question here. Which in-hospital treatment most improves outcomes in variceal hemorrhage? So I have 4 options for all of you. 1, beta blockers. 2, antibiotics. C is octreotide, and D is terlipressin. So I'll give a few seconds and go ahead and answer.
Okay, so we have maximum answers D, few are C. So C and D are the maximum answer. Most of the people have answered D. There are 2-3 responses with C and only 1 or 2 with A. So
Okay,
D is
got
the
it.
thing the people have replied. Yeah.
Okay, well, I'm glad I'm doing this because I feel like I'm contributing. The answer is actually B. So mortality benefit in terms of reduced infections is from using antibiotics in patients with upper GI bleeding. Now, this is known throughout with multiple studies, and this is a meta-analysis of almost 600-700 patients where giving antibiotics in these patients with variceal bleed has mortality benefit compared to controls. And the rationale and the reason is because patients with variceal bleeding have a high risk of infections, spontaneous bacterial peritonitis, bacteremia in these patients, and therefore prophylactic antibiotics reduces rate of mortality, and no other therapy has actually shown mortality benefit. Okay, so endoscopy and some form of drug therapy of vasopressors is superior to endoscopic therapy alone when you're managing these patients. So if you look at the risk of the chance of controlling bleeding, when you combine it with endoscopic therapy, it's much greater than only giving some sort of vasopressor therapy. Now, is there any preference? Not really. In India, terlipressin is available, and I was used to octreotide during my training years, which is also an option. And somatostatin. There's no difference in active bleeding when these 3 were used. No difference in treatment success rates. No difference in mortality, or no difference in rebleeding rates comparing 3 options. What are the predictors of rebleeding after a variceal bleed and mortality? So MELD score, I'm not sure if everybody's familiar with the MELD score, but this is a score which is computed with your INR, creatinine, and bilirubin, and it predicts your short-term mortality in patients with cirrhosis. So a MELD score which can be easily computed online, you can just put MELD and type it, and if the score is above 18, then they have a high risk of death, as you can see in this study. Anybody requiring more than 4 units of blood or active bleeding seen at endoscopy, and these are no-brainers. These patients have higher mortality. Again, decompensated cirrhosis, higher MELD score, child C, they again have high risk of rebleeding. Okay, and I'll show you this case here. This is a patient I was not involved myself, but one of my colleagues was involved in caring for this patient. As you can see here, this was performed at 5 a.m. Patient came with active bleeding, and urgent endoscopy was performed. As you see, there is active oozing and bleeding from this variceal bleeder. Banding, which would be your first line of treatment, was performed. The bands are placed with some degree of hemostasis. I'll just move forward here. But again, as you see, there is not adequate hemostasis achieved. I'll just move forward a little bit. There's still oozing from different sites. Well, I'll show you here. As you see, there's again pooling of blood and active bleeding. And now you're in a tough spot. It's 5 a.m. You have a patient. You're doing endoscopy. There's large amount of blood in the esophagus. The bands are not working. So what comes to rescue is what we now have available for us is an LR-Danis stent, which was placed, and I'll show you in a few seconds here. Some bands have also come off here in this case. So eventually, I don't have the fluoro images, but patient basically underwent stenting with an esophageal stent. And this is a specially designed stent for patients with variceal bleeding. This stent has a larger diameter than most esophageal stents in the market, which are generally used for cancer patients. And in this case, as the endoscope is being pulled back, I'll show you right here. This the stent is placed, and eventually the bleeding was controlled successfully. Okay. So esophageal stents can be used for acute variceal bleeding. This is a data of multiple studies. Overall, successful hemostasis was achieved in almost 80 to 100% patients. Rebleeding rates were variable from 0 to 40%, with 0% in most studies. There's a risk of migration, and mortality, of course, can happen because of worsening underlying liver disease. A recent randomized controlled trial comparing this LR-Danis specifically designed stent for variceal bleeding versus balloon tamponade, which is what you have to do otherwise, showed significant mortality benefit where patients with esophageal stenting had much better survival and compared to those without. I'll just showcase you some other therapies that we have available. Excuse me, I have to charge my laptop here for a second. So you have other therapies available, which include argon plasma coagulation. This is basically, this goes through the endoscope probe, and the argon gas is emitted, and then with electricity, you can actually perform cauterization of structures. It really creates a nice superficial burn and achieving adequate hemostasis. It's really useful in certain instances where your other methods are not applicable. This is a patient I actually did yesterday. Patient with cirrhosis came with melena since 1 month with gradual drop in hemoglobin. Now, this is important to note that patients who have bleeding from what we term here as gastric antral vascular ectasia. I'll just show you here. This is this antrum. And as you see, there are a lot of red spots all over. This is gastric antral vascular ectasia. And this leads to slow oozing of blood. And not like variceal bleeding where they suddenly have severe bleeding. So this blue probe here is the argon plasma coagulation probe. And then it's almost like painting. You have to have a good control because you don't want to inject the gas in the mucosa, and you can slowly and steadily apply current and target the vessels. And I'll show you how it looks later. You can just keep going on. It takes anywhere from 20 to 30 minutes and sometimes requires more than one session, which can be performed. And see, as you see, the entire mucosa is gradually ablated. Okay, just come back here. So we have achieved almost 80 to 90% of the mucosa is successfully ablated here. So this is another interesting case. This is a patient with blue rubber bleb nevus syndrome. This is a rare disease in which patients have mucosal venous malformations. As you see those blebs, as I showed you in the screen, I'll show you again here, right here at the bottom. This is a mucosal bleb, and this patient had GI bleeding, and then we ended up using APC to coagulate. This was an accidental puncture, as you see here. The mucosa, or the gas went inside the mucosa right there. So it's very important that you don't touch the probe to the mucosa. You have to maintain a very 5 millimeter to a centimeter distance between the probe and the mucosa. All right, so what other stuff is available? We have over the scope clips on the left here. These are very durable and very efficient clips, which can be placed as seen in this case here, or over the ulcers, because sometimes you have really hard base and therefore regular clips may not fit. And right as hemospray, the one by Cook is not available in India. There's a local one which is available. Now there are patients who have bleeding from tumors and sometimes just diffuse slow oozing, which cannot be controlled with regular methods. And in these cases, you can use hemospray. I've used it a few times. The spray basically is a polymer. When it comes in contact with liquid, it forms a nice layer which coats the wall of the mucosa and prevents bleeding. Now again, after 3 days, the coat goes away, and if the underlying lesion is not healed, then it will bleed again. So as a word of caution, if you're using this in cancer patients, this is not your ultimate solution. They may still bleed, but at least it achieves some degree of hemostasis initially when you want it. Okay, thank you so much. I'm happy to answer any questions.
Thank you, Saurabh. I'll hand over the proceedings to Rahate sir now, because he will be commenting first. Rahate sir.
Yeah, so Dr. Saurabh, it was quite an eye-opener lecture for us, and you have clean bolded many of us on your question answers. It was very fantastic. You have covered almost everything. I will ask you, because 4 of our 10 districts in Vidarbha, they don't have the
They don't have the what? Hello? Sorry, you're not audible.
Yeah, Rahate sir.
or the
We
they
lost
don't
you.
have the gastroenterologist to deal with. They don't have they don't have the facility to tackle endoscopically upper GI bleed.
Right.
Am I
right.
audible?
Yes, yes, yes.
Hello. So
Yes.
how what is your message if endoscope is not available? How to manage these patients there in periphery?
Right. See, I think firstly, you have 2 options here. One is you want to tackle it right there, or send the patient across to a gastroenterologist who can, or a surgeon who can handle it. So if you feel that the patient has a window of 24 hours, which, as I showed you from some randomized control data, that if the patient has melena, may have hemoglobin drop, patient has 24 hours to be transported, I think that would be the preferred way, where nearest facility where this can be performed. Now, if that is not an option, and in COVID-19 times there's no transport, then the question is, if you have a surgeon available, then I guess in ulcer bleeds, I'm sure surgery is definitely an option still. 1. 2 is in variceal bleeds. Stenting, of course, is difficult. I would suggest Sengstaken Blackmore tubes, which can be placed across the GE junction. And if you suspected cirrhosis bleeder, that's probably where the bleeding is coming from. Now, if it's really massive, then you can put a Sengstaken Blackmore tube, in which basically you insert this tube across the nose into the gastric cavity. It has 2 balloons. One is for the esophagus, the other one is for the stomach.
Yeah.
And you basically, under X-ray, ideally, if you can inflate or inject the saline and achieve adequate degree of compression of the varices, then you can at least salvage the patient and then get the patient transported. So that's what I would do if I was in the periphery. But yes, if you can transport, that will be the preferable way.
Yeah, thank you, Saurabh, for that answer. I just wanted that name, Blackmore. One more question. If a patient is having esophageal varices and fundal varices, which is to be managed first, and what is the sequence and what is the timing?
See, This is a good question, and I would like to explain that, you see, this will probably require another lecture in portal hypertension physiology, but what Dr. Ate is trying to elucidate is the fact that when you do therapy of one of the two, so if you say do therapy for fundal varices and you don't treat the esophageal varices, what ends up happening is the pressure in the esophageal varices will go up and the patient is at a risk of bleeding from the varices. So if you do therapy for one of the two, the pressure in the other system goes up. So ideally what you want to do is treat both. We start with the sequence of fundal varices first, and the idea being that once you put bands, you don't want to put the endoscope across in the stomach afterwards. So you start with fundal varices, put glue, or if you do EOS coiling, whatever you can, and achieve hemostasis, and then come back and then put bands on the esophageal varices. Other way sequence, the problem is that once you put bands and then you put endoscope across, you'll dislodge the band and patient will bleed. So that's the thought.
Exactly. Yeah. One more question. If the patient is on blood thinner, you have talked about the aspirin and clopidogrel, but if for some cardiac or for the brain, patient is on blood thinners like dabigatran or like that, so what is to be done if the patient bleeds?
See, I think patient who's actively bleeding, you're going to stop a dabigatran or clopitab. Aspirin is okay to continue, but stop clopitab or dabigatran when the patient is actively bleeding until you achieve hemostasis. Now, each of these neuroanticoagulants have their half-life, and sometimes 48 hours is, if I'm not mistaken, for dabigatran. And after 48 hours, the drug is out of your system enough that you can basically are normal coagulation levels.
Sir, can I add something to that?
Yeah,
Saurabh?
thank you.
So
Yes.
about dabigatran, I would like to
Please.
comment a thing, sir, because I had faced this situation at Orange City when I was new. So if you are using dabigatran, use it from a company called, one company which gives its antidote also. There is a company which gives antidote of dabigatran if your patient bleeds, because you don't have anything else other than that antidote in market. Like for heparin, we can give FFP and all. For dabigatran, the company person himself gets that antidote for the patient, which is free of cost. So if you are using that particular brand, I'll tell you in WhatsApp message what brand is. I won't take name here directly. So if you use that brand itself, the company people will give you the antidote. So better use that particular brand in which the antidote is available from company, which is free of cost. That is the best way to control the bleed of patient with dabigatran. I have faced it and I have used that antidote for my patient, and the bleeding had stopped significantly. And rest of the things as endoscopy and all those things, we can do that, but by that time we will also have to get that antidote. One more thing which sir was asking, if in periphery things happen like this and we don't have endoscopy or any expert to do banding or anything like that, I think each and every one of us should be very much well versed with medical therapy of bleeding varices, like how we start resuscitation, what is the dosage of octreotide in which we should start the patient, because it's not that they don't work, even they work, and they can give us a bit of relief in which the patient can be transported to the periphery center. So the medical management of variceal bleed is very important topic which we all should be very well versed with. How the dosage is to be given, whether it should be given in IV infusion pump or it should be like a bolus dose and all those things. We should learn these things very well in periphery setups so that we can give these things in 5 to 6 hours. If the tachycardia or a little bit patient gets settled down, then you can transfer the patient with that. That is the point I just like to make.
Yeah, so thank you for bringing that to my attention, Yogesh. I may have missed it in the slides. In terms of dosing for octreotide, which I'm used to, is 50 micrograms is the bolus dose, and then you continue it with 50 micrograms an hour. That's the dose you use, and you continue it for at least 72 hours. Sometimes you can do it for 5 days, and that can control your bleeding. So
Yes.
that's that. And the other issue was, again, as far as anticoagulants and active bleeding goes, I think it's also an issue of judgment, because if you have a patient with just a trivial bleed, which is probably stopped and has a mechanical valve, then I think your threshold to restart anticoagulation soon is much lower, versus somebody who is having massive bleeding and getting anticoagulation for a DVT 6 months ago. So I think the risk of any cardiovascular or clotting event versus worsening with the bleeding event needs to be weighed in every case on case-by-case basis. Yeah.
So Rate sir, I'll open the session for public now. I'll ask questions from public attendees. So the first question is from Dr. Rajendra Savji. Savji sir, you can unmute your mic and you can ask the question. I know what you want to ask, and I want that answer from Saurabh. Savji sir, please. Savji sir, you're online. I can see your hand raised. So Saurabh, he has put his question in the question pane here. So your surgical indications in secondary prophylaxis of EHPBO cases.
Yogesh, am I heard there?
Yeah, Savji sir, yes sir, yeah, go ahead with your question, sir, please.
My question, hello Saurabh, it was
Yes.
a wonderful lecture.
Yes.
My question to you is, role of surgery in secondary prophylaxis in case of extrahepatic portal venous obstruction.
So I think extrahepatic portal venous obstruction, for again, for all the audience, just a backdrop, it's basically non-cirrhotic patients who have portal vein obstruction can actually have portal hypertension and increased pressures. And actually the case I showed you with this variceal bleeding was this lady with EHPBO, and they have really high, very high portal pressures and a lot of bleeding events. Now, in my experience, which again is new because this is a new disease for me compared to West, which is extremely rare to have this. So largely, again, when we fail as gastroenterologists to achieve hemostasis, certainly in an acute setting if we can, or if there is persistent or recurrent bleeding that would definitely not be achieved successfully with our endoscopic therapies, I think would be where I would request someone like Dr. Savji or so to help with performing surgery.
How many?
Can you please highlight what your experiences with this and when would you do it? Yeah.
How many sessions of endotherapy you will offer in secondary prophylaxis until you invite surgeon into the management? In other words, when you will call endotherapy to be given up or is failed in secondary prophylaxis?
I see. Well, I would say, see, endoscopic therapy, generally, we could easily do it by, say, 3 to 5 times if it's largely esophageal varices. And then I would say maybe after 5 or 6 times after continuous banding you don't achieve, then probably at that point I would jump to, say, a surgical intervention. But again,
great.
there are other patients who have,
Great. Nice to hear that answer.
I'm sorry, what?
Great. That's nice to hear that answer from gastroenterologist. To involve.
Because people don't seem to manage. Well, no, what I mean to say is, say you do 5 times and then there is really no control, and then probably it's better to just for all. But certainly say, what's in terms of portal biliopathy. Now again, that's something that most audience may not, I don't know, have seen or not. But when these patients develop portal biliopathy, I guess then it's a hard situation.
Yes, very much.
So
Thank you, Saurabh. Thank you, Savji sir. Yeah, so we'll have another question. Dr. Vikas Jain has to ask something. Vikas sir,
yes,
your question, please. Vikas sir, I have.
Hello, Saurabh.
Yes, sir. Yes.
Sir, Saurabh, I am Dr. Vikas Jain from Gondia. I have one question, basic question. Basically, in periphery, whenever a patient of GI bleed, most of the time are the alcoholic cirrhosis or case of portal hypertension with GI bleed. Usually, we come to our setup and we start the cocktail treatment like rice tube aspiration and stomach wash, give antibiotic like monosafe, caplin, pause, silate, and give stomach wash and control the bleeding. By the time we do the coagulation profile and arrange the blood, and once the bleeding is slightly stopped, we go for bending. That is usually our protocol.
Sure, yes.
So what are the role of this supportive drug like pause or silate? Is they have any role?
Do you mean sucralfate?
No. Tranexamic acid and
I see, tranexamic. No, tranexamic acid, there have been large studies which have shown there's no benefit of tranexamic acid, and definitely no mortality benefit or any use. So that is not something that we use as standard of care now.
Okay.
Any
and
other
caplin?
drugs that you mentioned?
Vitamin K, caplin?
Right. So vitamin K is reasonable. So you see, if any patient with cirrhosis has coagulopathy and elevated INR, you really are looking at two options. Either it's vitamin K deficiency. They oftentimes have poor nutrition. They don't eat enough, and therefore the INR can go up. So that's easy to correct. And I would always start with vitamin K, absolutely, in every patient with cirrhosis. Now, again, whether INR truly reflects coagulation status, that's another debate which we can have. But by and large, INR is elevated, start with vitamin K. And then FFPs definitely in the acute setting when there's bleeding.
Yes, sir. Yes, sir.
INR above 0.5. Yes, goal to get it below 2. That should be the idea. Yeah.
And the finding, what in one of the patient is, I had seen patient has gastric varices as well as grade 3, grade 4 esophageal varices. I tried to bend the patient, but the size of varices was so much that it is not coming inside the bend. What to do in such condition?
See,
in one of the patients, the bend was very large. The varices was very large and it is not coming inside our scope.
Okay, so I think one option is, I've not particularly encountered whether vessel is large enough that it doesn't come in, but say if it truly were to be the case, you can either, there are small studies which have shown glue injection, very little data in esophageal varices as well. Sclerotherapy, which is not great, leads to ulcers and strictures, but that's what people used before I went into medical school. So that was what can be used, I suppose. And third, lastly, if you have access to interventional radiology, TIPS can be performed if the MELT score is below 18, and these patients can benefit if endoscopic therapy is really not an option in this patient. Then. So that
what is TIPS?
TIPS is transjugular intrahepatic. Yeah, so TIPS is transjugular intrahepatic portosystemic shunting. Now, again, I should close. This was surgery or IR related management. I did not discuss because of the vastness of the topic today. But TIPS is a way to put a stent across the liver, and then that reduces the portal pressures. And that can be done patients with Child's A, B, low MELT score patients with bleeding. Definitely gastric varices, large esophageal varices, you can't control. That would be a way. Of course, short of liver transplant, that's what you can do.
Yeah. Thank you, Vikas, sir.
One of the patient, one I am continuing. So one of the patient I lost, patient has large esophageal varices as well as gastric varices. I have done the bending of the esophageal varices, and post-operatively patient has 4 or 5 days patient has severe rebleed. I was not able to manage in Gondia, so I sent the patient to Nagpur. Patient reached to, I think, Rahate sir. That's what sir was asking, because the patient has large gastric varices and severe bleeding was there, and which I was not able to control, or maybe because I was not knowing this fact that when we do the bending of the esophageal varices, the pressure in the gastric varices increases. So how to manage such case, sir?
See, I think in this case, if you know and you feel that gastric varices is the source of bleeding, within 5 to 10 days, by that time, the bands would have sloughed off the esophageal varices. So in theory, most times you should be able to get the endoscope inside the stomach without dislodging the bands and causing problem. Again, you have endosonography is available, and then coiling and glue would be the preferred approach now, which is what I've shifted to now. or if you can just do regular endoscopy and glue injection of the varices, in the gastric varices, I mean. Now, what becomes challenging is if you have ulcer bleeding from the esophageal varices, because then your routine banding may not work, and then now you have
Yes, sir.
that second line, like, glue,
Yes, sir.
sclerotherapy, or stenting, as we showed in this case, where we placed the LR-Danis stent across. The problem is it's expensive. MRP is like 85,000 or something like that. So that is very expensive to put that stent, but that's only life-saving at this point. Again, these patients with cirrhosis then end up having, decompensation, worsening cirrhosis. You may salvage the bleed, but then they'll die because of infection and worsening underlying liver disease. So that ends up happening.
Thank you, Vikas, sir.
Okay,
We'll
thank
take
you.
the
Thank you,
next
sir.
question. Yeah. Next question is from Dr. Nishu Khemka. She has a question. Nishu Khemka. Yeah. Hello.
Yes.
Dr. Nishu, please go ahead with your question. Okay. We have Santosh. Online.
Yeah, you can also, anybody wants to put in questions, I can definitely answer them and send them emails
Subodh
later.
Gupta, sir, has a question. Dr. Gupta, sir. Subodh, sir, please ask your question. He had basically asked which antibiotic to be given to prevent the question which we had asked about which prevents really mortality. So in a variceal bleed in acute setting, what antibiotic which we prefer?
So the question is, right, the antibiotics. So the data that we go by, which is out of Spain from maybe I think 10, 15 years ago, was largely on ceftriaxone. Now, whether ceftriaxone works equally well in today's multi-drug resistant organism world is a matter of debate, because what you should actually do is, based on your local culture and sensitivity patterns in the hospital, you have to choose your antibiotics. So with all the MDR organisms now available, ceftriaxone may not necessarily take care of the bleeding. But again, it all depends on the local sensitivity and patterns of infections. But what you basically need is gram-negative and anaerobic coverage, because the most common organisms infecting are from the gut. And therefore, anaerobic gram-negative coverage is essential when you're treating.
So yeah, one last question now. This is from Dr. Siddharth Dhande. He has asked that a peptic ulcer bleed because of antiplatelet drugs, we have controlled it with endotherapy. Now H. pylori eradication has to be done, or whether the patient should be kept on lifelong PPI along with antiplatelet. So with antiplatelet, do we really have to give lifelong PPI? That is the question. One. And second, should we give H. pylori eradication to these patients also?
Right. So the first question is H. pylori eradication. Now, the options for testing H. pylori, you have serology, which tells you exposure, which is not useful in Indian context. You can do biopsies and check for H. pylori, but in active bleeders, you can't do that. Then you are left with breath test, and people are on PPIs. The breath test utility is less. So then what it leaves you with is actually empirically treat, which is what we do now. Given the prevalence of H. pylori, we don't actually test for them. The patient is empirically treated for H. pylori as soon as you find any peptic ulcer. Even if patients have a history of NSAIDs, we would still treat for H. pylori, assuming that that could be contributing, number one. Number two question is lifelong PPIs to give with antiplatelets. Yes, I would give lifelong PPIs. Primarily, well, which antiplatelets? Definitely, if you're, if you're on clopidogrel and you actually have an ulcer bleed, I would continue PPIs, because they can have, again, severe bleeding, one, and two is generally, by and large, in these situations, the downside of PPIs is actually low compared to the risk of rebleeding. So I know there's a concern with PPIs with CKD and ESRD patients and bacterial overgrowth, but in this case, we would continue.
Yeah. Thank you, Saurabh. So now we will close off the session. We have 2-3 residents who have want to ask question. I'd request them to put the mail to me as well as, yeah, Ashok sir, you are online. Ashok Gajbee, sir. Please ask your question, sir. Yeah. Ashok sir, unmute yourself. Ashok Gajbia sir. Yeah. Go ahead, sir.
Hello,
Yes, sir.
Saurabh.
Yes.
Hello, how to manage the Dulophy disease?
See, Dulophy lesions are what Dr. Gajbia is mentioning are submucosal vessels which come out of the mucosa. They don't
Yes.
actually have an overlying ulcer, but they just come out and they spurt and bleed. Generally, we can successfully use clipping, is what we generally do. If you have issues with that, then we have bipolar probes available, which can be advanced through endoscopes. And as I showed you in that ulcer bleeding case, you have to put pressure on it for 10 to 20 seconds, and then achieve.
Is there any role of epinephrine?
You can,
injection?
yes, similar to ulcer bleeding. Yes, you can. I mean, again, Dulophy's lesions are so rare that there's no large scale evidence data. But typically, since it's a blood vessel, I do use epinephrine. And again, as the concentration is 1:10,000, we can put about anywhere from 2 to 5 cc's or so in the submucosal tissue around it.
Okay, thank you.
Yeah. Thank you, Saurabh. So I request all the people who still have their questions to drop an email to me and Saurabh. We will surely reply you all the questions within a day or two. Okay. So it's already past 9:30 now. We have enough. We had enough discussion and a very good talk from Dr. Saurabh. I'm very sorry I can't take each and every question right now because it will take the time to 10. We will all reply your questions. Just put those questions on our mail. Within a day or two, we'll reply all those questions. Thank you very much. Saurabh, thank you for your excellent talk and all those things which you have cleared to us. Rahate sir, last word from you.
Yeah, thank you, Saurabh. It was wonderful. It was mesmerizing 1.5 hours.
Well, thank you so much for inviting me. It was truly an honor. Perfect. Thanks. I'm happy to answer all the questions.
One request, you become a one request. You become a member of VSA. Dr.
Yes.
Mukewar sir is already our member, so you have to be a member of our society.
So yes, thank you for the invitation. I'll definitely do it. I was
Sir,
waiting for my registration.
I'll make sure he becomes a member in a day or two.
Thanks.
Okay.
Okay.
Thank you, Saurabh. Thank you, sir. Yeah.
Thank you. Bye-bye.